Does he really just have ADHD? How one brain MRI uncovered an inborn error of metabolism. A 5-year-old boy was brought to a pediatric neurology clinic by his parents. He was hyperactive and impulsive, and he struggled to pay attention. He frequently had temper tantrums. He would erupt in sudden rage. He also showed destructive behavior, physical aggression toward others, and repeated headbanging. A standardized assessment showed that he met the diagnostic criteria for attention deficit/hyperactivity disorder, or ADHD, combined presentation. And there was little on his neurologic examination to raise alarm. It was almost completely normal. The story seemed to have an answer. Then magnetic resonance imaging of the brain, a brain MRI, changed the entire direction of the case. Doctors eventually discovered that this child had an inborn error of metabolism, or IEM, L2-hydroxyglutaric aciduria, or L2HGA. This was a real case published in BMJ Case Reports in 2021. Next, we'll follow the trail of clues the medical team uncovered, and we'll see how an IEM hidden beneath a ADHD-like behavior was finally discovered. Chapter 1. The behavior stood out, but his developmental history exposed the cracks. Clue 1. He wasn't just a child who couldn't sit still. By age 3, he was already noticeably hyperactive and impulsive. He had great difficulty sustaining his attention. Before L2HGA was diagnosed, he could stay focused for only about 2 minutes at a time. He also had repeated temper tantrums, angry outbursts, non-compliance, stubborn behavior, and disruptive and destructive behaviors. One behavior was especially troubling to his parents: headbanging. The case report did not describe exactly when the headbanging occurred or how often it happened. But follow-up after his L2HGA diagnosis and treatment clearly documented that the behavior disappeared completely. If these were the only signs, ADHD might seem to fit. But when the doctors looked more closely at his developmental history, they found a second clue. Clue 2. Significant language delay. His motor development had been largely normal, but his language development was far behind. At age 3, his vocabulary included only about 50 words. He did not begin using 2-word phrases until age 4. When he was evaluated at age 5, his receptive language skills were at the level of a 30 to 33-month-old. His expressive language skills were at the level of a 24 to 27-month-old. His social age was about 3.2 years, with a social quotient of 61. In other words, his difficulties extended beyond attention and behavior. His language, communication, and adaptive functioning were also well below what would be expected for his age. These findings cannot diagnose an IEM on their own, but they showed that ADHD alone could no longer explain the whole picture. Clue 3. A febrile seizure. At age 3, the boy had one simple febrile seizure. His sister also had a history of febrile seizures, and one of his maternal aunts had an intellectual disability. The case report did not establish a direct connection between these family history findings and L2HGA. So they could only be treated as background clues, not proof of a connection. At birth, he had also experienced umbilical cord prolapse, a delayed first cry, and neonatal jaundice. But there was no documented neonatal encephalopathy. The doctors did not assume that these perinatal events had caused his later behavioral problems. The test that truly changed the direction of the investigation came next. The critical turning point, an unusual pattern on brain MRI. The boy's muscle strength, muscle tone, and reflexes were all normal. He had no ataxia, no dystonia, and no clear pyramidal, cerebellar, or extrapyramidal signs. But his brain MRI told a very different story. Symmetric signal abnormalities were present in the subcortical white matter on both sides of the brain. By contrast, the periventricular and deep white matter were relatively spared. Abnormal signals were also seen in the caudate nuclei, puttamina, globi pallidi, and dentate nuclei. The peripheral portions of the caudate, nuclei, and puttamina were brighter than their central regions. The cerebellar white matter showed no clear involvement. The cerebral sulci were widened, and portions of the subcortical white matter appeared thinned. Taken together, this pattern of involvement, the subcortical white matter, the basal ganglia, and the dentate nuclei, strongly suggested L2HGA. Doctors also considered other possible diagnoses. These included Leigh syndrome, propionic acidemia, glutaric aciduria type 1, and Wilson disease. The MRI pointed them in a specific direction, but it could not establish the diagnosis on its own. They still needed metabolic evidence. The urine revealed a metabolic fingerprint. Urine organic acid analysis using gas chromatography mass spectrometry showed a striking result. The child's urinary 2-hydroxyglutaric acid level was close to 4,000 millimoles per mole of creatinine. The reference cutoff for this test was only about 433. That was a marked elevation. But one question remained. 2-hydroxyglutaric acid comes in two forms, the L form and the D form. A routine urine organic acid test may detect an elevated level without determining which form is present. To confirm the specific form, a laboratory can use a test capable of chiral separation. Doctors can also look for a corresponding genetic variant. In this case, they chose genetic testing. Genetic testing pinpointed the defect. Testing identified a homozygous variant in the L2HGA gene, C.293A to G, resulting in the protein change P.his98RG. The paper classified the variant as likely pathogenic. Several in silico prediction tools also suggested that it could impair protein function. In simple terms, the L2HGA gene provides instructions for making a metabolic enzyme. That enzyme depends on flavin adenine dinucleotide, or FAD. Its job is to process L2-hydroxyglutarate. When the enzyme does not function well enough, L2-hydroxyglutarate accumulates abnormally. That buildup is associated with changes in the brain. The urine findings, the characteristic MRI pattern, and the genetic result all pointed to the same diagnosis. At last, the diagnosis was clear. L2-hydroxyglutaric aciduria, or L2HGA. The child's prominent ADHD-like symptoms may also have been part of the clinical presentation of L2HGA. Treatment, addressing the metabolic disorder and the behavioral symptoms. After the diagnosis, the child began riboflavin treatment. He received 60 milligrams per day, about 3 milligrams per kilogram of body weight per day. He was also given levocarnitine. The dose was 1,000 milligrams per day, about 50 milligrams per kilogram per day. He was also placed on a low-protein diet. Riboflavin helps form FAD, the cofactor required in this metabolic pathway. But the response to treatment may vary from one patient to another. Individual factors, including residual enzyme activity, may affect the response. Another group of interventions focused directly on the child's day-to-day difficulties. These included speech therapy, behavioral intervention, attention training, and parent guidance. The clinical team used positive reinforcement to increase desired behaviors and reduce impulsive behaviors. They gradually worked on his language, his ability to wait, and his ability to follow directions. 6 months later, changes began to appear. The child was evaluated again 6 months after treatment began, and then at 1 year. His parents reported that his temper tantrums, angry outbursts, and destructive behavior gradually became less frequent. His hyperactivity and impulsivity improved significantly. His attention span increased from about 2 minutes to 6 minutes. He became better able to wait, and he was more willing to follow directions. The headbanging behavior that had worried his parents stopped completely. His receptive and expressive language skills also improved to an age-equivalent level of about 3 to 3.5 years. Later, when he was approximately 6.3 years old, he underwent an adaptive behavior assessment. His communication, daily living skills, socialization, and motor skills were still below expected levels. He had made progress that could be observed and measured, but significant gaps in his development and adaptive functioning were still present. What does this case really teach us? The message is not that every child with ADHD should undergo a brain MRI and genetic and metabolic testing. A single simple febrile seizure should not automatically be treated as a warning sign of metabolic disease. For a neurologically healthy child whose seizure meets the definition of a simple febrile seizure, routine testing with an electroencephalogram, or EEG, blood tests, or brain imaging is generally not recommended. What deserves closer attention is the appearance of several clues at the same time. For example, attention problems, hyperactivity, or severe behavioral symptoms, together with language delay or global developmental delay. Adaptive functioning that is clearly behind what would be expected for the child's age. Developmental regression, seizures, or an abnormal head circumference, a movement disorder, abnormal findings on the neurologic examination, or other features that suggest a genetic syndrome. At that point, the clinician needs to ask again, does the current diagnosis explain everything happening in this child? This boy truly did meet the diagnostic criteria for ADHD. But ADHD could not explain his language delay, his impaired adaptive functioning, or his abnormal MRI. Because those smaller clues were not dismissed, they eventually came together to reveal the full diagnosis of L2HGA. One of the most important moments in medical detective work is often not the discovery of one dramatic symptom. It is the realization that several seemingly ordinary findings should not all be appearing in the same child. Chapter 2. What exactly is L2HGA? A small malfunction inside the mitochondria. How can it affect a child's language, cognition, behavior, and movement? To find the answer, we need to begin with a seemingly minor processing error inside the cell. So, what exactly is L2HGA? L2-hydroxyglutaric aciduria, or L2HGA, is an inborn error of metabolism, or IEM. It primarily affects the central nervous system. It is caused by biallelic pathogenic variants in the L2HGDH gene, and it follows an autosomal recessive inheritance pattern. When both copies of the L2HGDH gene carry pathogenic variants, the mitochondrial enzyme L2-hydroxyglutarate dehydrogenase does not function properly. As a result, L2-hydroxyglutarate, or L2HG, cannot be processed efficiently. Its levels gradually rise in tissues, blood, cerebrospinal fluid, or CSF, and urine. The word Aciduria is part of the disease name, but the brain is the main battleground. People with L2HGA may develop developmental delay, learning difficulties, cognitive impairment, language problems, seizures, ataxia, tremor, dystonia, spasticity, and an enlarged head circumference, known as macrocephaly. presentation can vary widely from one patient to another, and a normal head circumference does not rule out the disease. L2HGA usually progresses slowly. It often leaves clues during childhood, but the diagnosis may not be made until many years later. Unlike some organic acidemias, L2HGA rarely causes repeated, obvious episodes of acute metabolic crisis. A child may never suddenly lapse into a coma. There may be no single dramatic metabolic collapse. Instead, the damage can build gradually over many years. That slow accumulation is one reason L2HGA can be so easy to miss. Chapter 3. Where does the metabolic assembly line break down? Inside the tricarboxylic acid cycle, or TCA cycle, there is an important molecule called alpha-ketoglutarate. It is also known as 2-oxoglutarate. This molecule participates in energy metabolism. It also serves as a substrate for many different enzymatic reactions. Malate dehydrogenase normally works with malate and oxaloacetate. But enzymes are not always perfectly selective. Every now and then, an enzyme can pick up the wrong substrate. In the presence of reduced nicotinamide adenine dinucleotide, or NADH, malate dehydrogenase can convert alpha-ketoglutarate into L2HG. This is a very inefficient side reaction. Early biochemical research found that mitochondrial malate dehydrogenase performed this side reaction about 10 million times less efficiently than its normal reaction. For cytosolic malate dehydrogenase, the side reaction was about 100 million times less efficient. With efficiency that low, how could it possibly become a problem? Because cells contain large amounts of malate dehydrogenase, and alpha-ketoglutarate is always present. So even with a very low error rate, small amounts of L2HG continue to be produced. A healthy cell already has a rework specialist ready to deal with this mistake. That specialist is L2-hydroxyglutarate dehydrogenase. The enzyme is encoded by the L2HGDH gene and is located inside mitochondria. It uses FAD as a cofactor to oxidize L2HG back into alpha-ketoglutarate. Alpha-ketoglutarate leads to a low-efficiency side reaction of malate dehydrogenase. Arol-2-hydroxyglutarate, Arol-2-HGDH, plus FAD-alpha-ketoglutarate. Researchers therefore describe L2HGDH as a metabolite repair enzyme. Its job is to clean up an abnormal product that another enzyme creates by accident. When L2HGDH loses its function, the side reaction keeps happening. But the cell's ability to recycle the product falls dramatically. L2HG begins to accumulate. Imagine a warehouse receiving a small delivery every day, while the person responsible for clearing the inventory never comes to work. Nothing looks unusual after a single day. But after several years, the warehouse is slowly packed full. The 5-year-old boy from the beginning of this story provided 3 matching pieces of evidence. First, his urinary 2-hydroxyglutaric acid was markedly elevated. Second, his MRI showed the characteristic subcortical white matter, basal ganglia, and dentate nucleus abnormalities seen in L2HGA. Third, genetic testing identified a homozygous, likely pathogenic variant in L2HGDH. When those 3 pieces were put together, the diagnostic direction became clear. Is L2HG really just metabolic waste? A study published in Nature in 2026 provided a new clue. The researchers found that under normal conditions, low concentrations of L2HG may participate in cellular signaling. When mitochondrial NADH rises, the ratio of NADH to its oxidized form, nicotinamide adenine dinucleotide, or NAD+, also increases. Under those conditions, mitochondrial malate dehydrogenase 2, or MDH2, produces more L2HG. L2HGDH then oxidizes it back into alpha ketoglutarate, helping keep its concentration under control. You can think of NADH as a fleet of trucks carrying high-energy electrons. When too many of those trucks begin to back up, alpha ketoglutarate is more likely to be pushed toward L2HG. But we need to distinguish between two very different states. The first is the low, tightly controlled level of L2HG found in healthy cells. The second is the prolonged, uncontrolled accumulation that follows L2HGDH deficiency. The first may participate in normal cellular signaling. The second is associated with the white matter disease and neurologic dysfunction seen in L2HGA. This study relied mainly on cultured cells, mouse embryonic stem cells, and experiments involving mouse kidneys. It did not establish what specific role low levels of L2HG might play in the human brain, so we can now update our original analogy. L2HG may not be completely useless metabolic waste. The central problem in L2HGA is that its concentration escapes control and remains abnormally elevated for a long time. Chapter 4. Why is the brain especially vulnerable? MRI has already mapped the regions that are affected, but the complete molecular chain of brain injury has not yet been worked out. In one MRI study of 56 genetically confirmed patients, abnormalities most often involved the frontal and subcortical white matter. As the disease progressed, the lesions became more confluent and spread inward from the outer regions. All 56 patients had abnormalities in the caudate nuclei and putamen. 55 had abnormalities in the globus pallidus, and 55 had bilateral abnormalities in the dentate nuclei. The cerebellous white matter was not affected in any patient in this cohort. Patients with a longer disease duration were more likely to show white matter atrophy. Those bright abnormalities on MRI reflect real tissue damage. An autopsy in one severely affected patient found spongiform changes and cystic cavities in the subcortical white matter. Tiny vacuoles and astrocytosis were also found around the dentate nucleus. But this was only one case. It cannot represent every person with L2HGA. At present, there are 4 main clues to how the brain may be injured. Clue 1. Energy handling may be disrupted. The brain consumes an enormous amount of energy. Neurons constantly need to move, store, and rapidly mobilize that energy. In cerebellar tissue from developing rats, researchers found that L2HG could inhibit mitochondrial creatine kinase. This enzyme helps cells rapidly mobilize stored energy when energy demand suddenly increases. Researchers have therefore proposed that creatine kinase inhibition may contribute to injury in nervous tissue. Some early case reports also described abnormalities in lactate or metabolites related to the TCA cycle. Those findings led to the hypothesis that brain energy metabolism may be disrupted in L2HGA. But these abnormalities do not appear in every patient. And no human study has shown that elevated lactate directly causes the white matter damage or psychiatric symptoms seen in L2HGA. This clue deserves further investigation, but it does not yet provide a firm conclusion. Clue 2. Oxidative stress may damage neurons and myelin. When reactive oxygen species, or ROS, exceed a cell's ability to neutralize them, they can damage proteins, cell membranes, and myelin. Studies involving rat brain tissue and direct administration of L2HG into the brain found that L2HG may increase ROS and lipid peroxidation. It may also weaken some of the brain's antioxidant defenses. Later animal studies found reductions in markers associated with neurons and myelin. Astrocytes and microglia also became activated. The animals later developed motor and cognitive abnormalities. These results support the possibility that oxidative stress contributes to brain injury. But the evidence comes mainly from animal and laboratory studies. It does not prove that ordinary antioxidant supplements can slow the disease in patients, and it does not justify using experimental drugs without medical supervision. Clue 3. The way glutamate is handled may be altered. Glutamate is an important neurotransmitter, but the results of these experiments are often interpreted far beyond what they actually showed. In preparations from rat cerebral cortex, L2HG increased glutamate uptake by synaptosomes and synaptic vesicles. But glutamate release did not change significantly, and glutamate binding to its receptors did not change significantly either. The original researchers made one point very clear. Their results did not support a direct glutamatergic excitotoxic effect of L2HG. The most cautious conclusion is that L2HG may alter how glutamate is handled and stored. How much that change contributes to neurodegeneration in L2HGA remains unclear. Clue 4. The metabolite may affect gene expression. The 2026 Nature study also found that L2HG could affect the lysine demethylase 4, or KDM4, family of histone demethylases. In mouse embryonic stem cells, L2HG altered gene regulatory marks, such as trimethylation of lysine 9 on histone H3, a mark known as H3K9ME3. It also suppressed the transcription of certain genes. That means changes in metabolite concentration may influence how cells decide which genes to turn on and which genes to turn off. But once again, this evidence comes from cell and animal studies. This investigation is still missing several final pieces. What we have right now looks less like one finished explanation and more like several investigative threads moving forward at the same time. Disrupted energy handling, increased oxidative stress, damage involving myelin and glial cells, changes in glutamate handling, and altered regulation of gene expression. All of these processes may contribute to brain injury in L2HGA. But which one matters most? Do the mechanisms differ according to age, genetic variant, or residual enzyme activity? We do not yet have definitive answers. What we can confirm is this. When L2HGDH loses its function, L2HG remains abnormally elevated over a long period of time. The brain gradually develops characteristic abnormalities in the white matter and deep gray matter nuclei. But how those abnormalities are translated step by step into language delay, unstable attention, irritability, seizures, tremor, and ataxia is a chain of events that medical research is still working to complete. The easiest part of L2HGA to miss is hidden in its slow progression. The original metabolic side reaction is very small, but the time available for accumulation is very long. By the time behavioral, learning, or movement problems become obvious, that poorly cleared metabolic warehouse may have been filling up for years. Chapter 5. Why is L2HGA so easy to miss? A 5-year-old boy was diagnosed with ADHD because of hyperactivity, impulsivity, and headbanging. A 13-year-old boy came to the hospital with anxiety, fearfulness, and learning difficulties. A 15-year-old girl developed an abnormal posture in her right hand whenever she wrote. Later, the same problem affected her left hand. And then there was a 32-year-old man. He was forgetful. Both hands trembled. He slept about 16 hours a day, and he needed help just to shave. These presentations seem completely different, yet all of them ultimately pointed to the same IEM, L2-hydroxyglutaric aciduria, L2HGA. That is precisely why the disease can be so easy to miss. It does not always begin with classic ataxia or obvious dystonia. The first visible problem may simply be declining school performance, anxiety, uncontrolled anger, or one hand that becomes increasingly difficult to control. Sometimes late onset really means late recognition. A retrospective study of 25 people with L2HGA found that the mean age at the first appearance of symptoms was 39.47, plus or minus 29.96 months. The mean age at diagnosis was 12.09 plus or minus 8.02 years, and the mean diagnostic delay was 9.95 plus or minus 7.78 years. Common early clues included developmental delay, declining school performance, and seizures. As the disease progressed, behavioral problems and seizures could become more prominent. So the term late onset may describe two different situations. In the first, symptoms truly begin later in life. In the second, the clues were already present during childhood, but went unrecognized for many years. When many adults who receive a late diagnosis look back through their medical history, they can still find traces of the disease in childhood. An anxious 13-year-old boy. One 13-year-old boy was evaluated for excessive anxiety, learning difficulties, and a tremor of the head. He was socially withdrawn. His fine motor skills were poor. His handwriting was difficult to read, and other students frequently made fun of him. In social situations, he was afraid of embarrassing himself. Whenever he had to speak or perform in front of other people, his anxiety became even worse. If these were the only features being considered, it would have been easy to focus entirely on anxiety and social difficulties. But the pediatric neurologic examination revealed much more. He had an intention tremor, truncal ataxia, dysmetria, dysdiadochokinesia, difficulty performing rapid alternating movements, and dysarthria. In other words, he was not simply anxious. His hands, trunk, movement coordination, and speech all showed neurologic abnormalities. MRI and urine organic acid testing ultimately pointed to L2HGA. After he began treatment with riboflavin and levocarnitine, the case report documented reductions in his anxiety, fearfulness, tremor, and dysarthria. The tremors in his hands and head had disappeared by the 5th month. But his learning difficulties remained. In adults, the clues may be even more scattered. Another report described 2 adult brothers with L2HGA. The older brother, age 32, had chronic headaches and forgetfulness. He slept about 16 hours a day. Both of his hands trembled intermittently. He needed help shaving, and his impulsive behavior had increased. His 29-year-old brother initially complained mainly of back pain, but he also had impulsivity and difficulty controlling his anger. Further examination revealed that he had trouble initiating rapid eye movements called saccades. He also had mild tremor, dystonia, spasticity, and impaired coordination. MRI in both brothers showed severe symmetric leukoencephalopathy. These problems had not suddenly appeared out of nowhere in adulthood. Both brothers had experienced developmental delay and mild intellectual disability during childhood. The forgetfulness, excessive sleepiness, impulsivity, and movement abnormalities that emerged in adulthood simply made the long-standing disease pattern more visible. Sometimes the first clue is just a pen. One 15-year-old girl had noticed a problem since the age of 8. Whenever she wrote with her right hand, the hand developed an abnormal posture, so she switched to writing with her left hand. 2 years later, the same problem began affecting that hand as well. Eventually, even using eating utensils and working on a computer became difficult. Her gait was normal, and she had no seizures. The main clues were slower development, mild cognitive difficulties, slight scanning speech, and task-specific dystonia during writing, also known as writer's cramp. A characteristic MRI pattern, elevated urinary 2-hydroxyglutaric acid, and genetic testing ultimately confirmed L2HGA. A pen that became increasingly difficult to control had opened the door to the diagnosis. The psychiatric and behavioral presentation can be very broad. Individual pediatric cases have reported severe autism-like features, and the authors of the 25-patient cohort described a wide range of behavioral manifestations, extending from autism spectrum disorder to psychotic symptoms. Chapter 6, which red flag clusters call for a broader workup. Hyperactivity, anxiety, forgetfulness, or irritability on their own usually are not enough to point strongly to an inborn error of metabolism. What should raise concern is when these symptoms appear alongside other red flags. For example, delayed language, motor, or overall development, or the loss of skills a child had already acquired, long-standing learning difficulties, or a gradual decline in school performance, epilepsy, recurrent unexplained episodes, or a change in a person's usual seizure pattern, tremor, writer's cramp, clumsiness, an unsteady gait, or slurred speech, dystonia, spasticity, abnormal reflexes, or difficulty initiating saccadic eye movements, psychiatric or behavioral symptoms combined with a slow decline in cognitive, language, or motor skills. Brothers or sisters with similar developmental, seizure, or movement-related problems, and an MRI showing symmetric abnormalities in the subcortical white matter, basal ganglia, and dentate nuclei. An enlarged head circumference, or macrocephaly, is another possible clue, but a normal head circumference does not rule out L2HGA. There is another important point. Psychiatric or behavioral symptoms in isolation do not rule out an IEM. Some later-onset inherited metabolic disorders may first present with depression, psychosis, attention problems, behavioral changes, or cognitive decline before obvious physical symptoms appear. The 5-year-old boy we discussed earlier is a powerful reminder. His strength, reflexes, gait, and coordination showed no clear abnormalities. What pushed his doctors to investigate further was his language delay, his low level of adaptive functioning, his history of a febrile seizure, and the characteristic abnormalities later found on MRI. A normal neurologic examination cannot erase the other red flags hidden in the medical history. Chapter 7. Diagnosing L2HGA. 4 stops along the evidence trail. The first stop is MRI. A typical MRI shows bilateral, relatively symmetric abnormalities in the subcortical white matter. Early in the disease, the frontal lobes and subcortical U fibers are often involved. Over time, the affected areas become more confluent and gradually spread inward. The periventricular white matter, internal capsules, corpus callosum, and brainstem are usually relatively spared. The caudate nuclei, putamina, globi pallidi, and dentate nuclei are frequently involved. The cerebellar white matter is usually spared. This imaging pattern is highly recognizable, but MRI can only create a strong suspicion. It cannot confirm the diagnosis on its own. Doctors still need to consider other possible diagnoses, including Canavan disease, glutaric aciduria type 1, Lee syndrome, propionic acidemia, thiamine-responsive basal ganglia disease, and Wilson disease. The second stop is urine organic acid testing. Gas chromatography, mass spectrometry, or GCMS, can detect a marked elevation of 2-hydroxyglutaric acid in the urine. But there is an important limitation. Some people with L2HGA may still have normal results for blood ammonia, lactate, glucose, blood gas analysis, plasma amino acids, and acylcarnitines. Normal routine metabolic blood tests do not rule out L2HGA. The third stop involves a mirror image problem. Which form of 2-hydroxyglutaric acid is elevated? The L form or the D form? Routine urine organic acid screening can usually detect an elevated total level, but it may not distinguish between the two enantiomers, the two mirror image forms of the molecule. Specialized laboratories can use chiral GCMS or chiral liquid chromatography, tandem mass spectrometry, known as LCMS/MS, to measure the L and D forms separately. This step can help distinguish among 3 different disorders: L2-hydroxyglutaric aciduria, or L2HGA, D2-hydroxyglutaric aciduria, or D2HGA, and combined DL2-hydroxyglutaric aciduria, or DL2HGA. The fourth stop is genetic testing. If testing identifies biallelic pathogenic or likely pathogenic variants in the L2HGDH gene, and those variants fit the patient's clinical picture, the genetic cause can be confirmed. A variant of uncertain significance, or VUS, cannot establish the diagnosis on its own. Variant classifications may also change as databases are updated and new evidence becomes available. If the clinical picture is atypical, a specialist may consider a relevant multi-gene panel, exome sequencing, or genome sequencing. But these tests also have limitations in their coverage and in the types of variants they can detect. Even here, the evidence trail is not quite complete. The final step involves the entire family. Why should family members be evaluated after a diagnosis? L2HGA follows an autosomal recessive inheritance pattern. Most affected children have parents who each carry one altered copy of the gene. The parents themselves usually have no symptoms. If both parents are confirmed to be carriers for L2HGA, then with each pregnancy, there is a 25% chance that the child will be affected, a 50% chance that the child will be a carrier, and a 25% chance that the child will be neither affected nor a carrier. After diagnosis, families may need to discuss testing the parents, testing brothers and sisters, and future reproductive options. These decisions should be made with the support of genetic counseling. Chapter 8. Can L2HGA be treated? At this time, there is no approved disease-modifying therapy for L2HGA, and no randomized controlled trial, or RCT, has shown that any medication can reliably alter the course of the disease. Current treatment experience comes mainly from biochemical reasoning, case reports, and small case series. Riboflavin. The rationale makes sense, but responses have been inconsistent. After riboflavin enters the body, it can be converted into flavin adenine dinucleotide, or FAD. L2-hydroxyglutarate dehydrogenase is an FAD-dependent enzyme. So the theory is straightforward. If a patient still produces some functional enzyme protein, increasing the supply of FAD might improve or stabilize the remaining enzyme activity. But there is currently no reliable way to predict treatment response from a patient's genetic variant. In one case, a 16-year-old patient received 100 milligrams of riboflavin per day for nearly 2 years. The report documented partial improvement in motor and cognitive performance. Urinary L2-hydroxyglutarate fell from 5,990 to 1,490 millimoles per mole of creatinine. But another patient began the same daily dose of 100 milligrams at age 14. Treatment continued for 6 months. The result? There was no clinical improvement, and urinary metabolite levels did not improve meaningfully. The researchers suggested that variants causing protein truncation or abnormal splicing might leave too little residual enzyme for riboflavin to help. But this remains a case-level explanation. A response to riboflavin cannot be guaranteed in advance, and doses used in individual case reports should not simply be copied. Whether riboflavin should be tried, how much should be used, and how the patient should be monitored must be decided by a specialist in inherited metabolic disorders, levocarnitine and low-protein diets. Several case reports have used levocarnitine, riboflavin, and other nutritional supplements together. Low-protein or low-lysine diets have also been tried, mainly on the basis of individual case experience. But a substantial amount of L2-hydroxyglutarate is continuously produced inside the body through an ongoing metabolic side reaction. Simply reducing one component of the diet may not stop that production. Restricting protein without medical supervision can also lead to inadequate intake of calories, protein, and essential micronutrients. Any dietary plan should therefore be developed jointly by a metabolic specialist and a dietitian. It should not be copied from a case report found online. At the same time, seizure treatment, management of movement disorders, speech and language therapy, behavioral interventions, physical therapy, occupational therapy, and school-based support remain essential parts of long-term care. Chapter 9. Another long-term risk. Brain tumors follow-up for L2HGA cannot focus only on seizures or whether a person can still walk steadily. A 2012 review of the literature included 295 patients with L2HGA. 14 of them had brain tumors. That equals 4.75%. But this number came from a collection of published cases, not from a prospective population-based study, so the true lifetime risk remains uncertain. The estimate may also be affected by publication bias. There is currently no universally accepted interval for repeat MRI scans. Recent literature suggests that specialist teams should develop individualized plans for contrast-enhanced MRI surveillance based on the patient's age, previous imaging, and changes in clinical symptoms. If a patient develops a new and persistent headache, a change in consciousness, focal neurologic signs, rapid loss of function, or a sudden change in an established seizure pattern, the patient should receive prompt medical evaluation. The treating physician can then decide whether an MRI needs to be repeated without delay. Conclusion: L2HGA is rare, but the ways it gets missed are surprisingly ordinary. A child may first present with hyperactivity, delayed language, falling grades, or frequent angry outbursts. A teenager may come to the hospital because of anxiety, tremor, or handwriting that is becoming harder to control. An adult may notice only forgetfulness, excessive sleepiness, impulsivity, or difficulty controlling anger. Or they may realize that their hands and legs are slowly becoming harder to control. The question doctors need to ask is, what other clues are appearing alongside these symptoms? Developmental delay, seizures, abnormal movements, slow loss of function, an unusual family history, or symmetric white matter abnormalities on MRI. When several of these clues appear together, the evaluation should not end with a psychiatric or behavioral diagnosis. Urine organic acid testing, Chiral analysis of 2-hydroxyglutaric acid and L2HGA genetic testing can connect symptoms that have been scattered across years into one continuous chain of evidence. Once the diagnosis is established, patients can receive more appropriate care for seizures, movement problems, language difficulties, behavioral symptoms, and rehabilitation needs. Doctors can also begin considering surveillance for brain tumors. Families can learn about their genetic risks, and case-based treatment approaches involving riboflavin, levocarnitine, or dietary changes can be considered under specialist supervision. The 5-year-old boy's ADHD diagnosis was not automatically erased when L2HGA was discovered. He did meet the diagnostic criteria for ADHD. ADHD described what his doctors were seeing: inattention, hyperactivity, impulsivity. But L2HGA helped explain the other pieces of his history: his language delay, his impaired adaptive functioning, his febrile seizure, and an MRI pattern that was strikingly characteristic. ADHD answered the question: what was the child showing? L2HGA helped the doctors investigate. Why did this entire cluster of problems appear together? Finding L2HGA does not automatically eliminate the coexisting ADHD phenotype. And this is the diagnostic opening that milder or late recognized L2HGA so often leaves behind. The symptoms on the surface already have a name, but the full medical history still lacks a cause that can explain the whole picture.